1, 2, 3. We are live.
Great.
We'll
So,
start the
Suman
record.
sir, Ashish sir, we can take it forward.
Yeah, Suman, go ahead.
Suman sir, you can start.
Hello. Hello.
Yeah, you're audible.
Sorry, I missed. Doctor. Did Ashish sir do the introduction?
Yeah.
No, not yet. He has asked you to start.
Okay. So, good evening all. So today we have one more session of Nurture the Future, where we are going to discuss about malignant bone tumors and its treatment. I like Dr. Ashish Guria sir to just give an introduction about the session, and then we'll go through the main program.
Good evening, everyone, and thanks for joining us for this special session on malignant bone tumors. As we all are aware, that musculoskeletal oncology, the major chunk is all about management of malignant bone tumors, and this is one area which is quite deficit in our postgraduate training, and hence we thought to compile these special sessions where we'll be discussing various aspects of management of malignant bone tumors. Just to highlight that we as surgeon cannot treat these tumors alone, and hence we require a multidisciplinary approach which encompasses various subspecialties like radiology and pathology for appropriate diagnosis. And to execute the treatment based upon this diagnosis, we need support from our colleagues from radiotherapy and medical oncology. And hence we decided that we will have these sessions, which will have a couple of unique talks to start with, and then we will discuss various aspects with our case-based management. And today's quiz is going to be pretty interesting, and I really hope that this will add a lot of benefit for the postgraduates who have been attending these webinars. Over to you, Suman. And thank you so much, Suman, for coordinating the entire thing. And obviously, I'm sure that with efforts from various eminent orthopedic oncologists like you, Dr. Vivek, Dr. Badira, Dr. Nehal, and Professor Vivek Ajit Singh, who has joined us from Malaysia, we will be able to pass on various tips and tricks for the management of these tumors. Thank you so much, Suman.
Thank you so much, sir. So let's not waste time. We'll go to our first topic, that is the principles of bone sarcoma surgeries. Will be delivered by Professor Vivek Ajit Singh. A small introduction about Professor Vivek. So he works at the University of Malaya. So he did his fellowship in oncology from Birmingham Orthopedic Hospital in 2004. So he's into this oncology practice for more than 16 to 18 years now, and he is head of this hospital. Accepting our, you can start your talk.
Are you all able to see my my slide?
Yes, Vivek, you are audible and visible both. Thank you.
Yes.
Yes. So first of all, I'd like to thank Suman and Ashish for inviting me to join your CME. So, yes. Okay. So I'll be talking on principles of bone sarcoma surgery. first of all, when we talk about bone sarcoma surgery, we have to understand the biology of sarcoma. As we know, sarcomas originate from mesenchymal cells that form the fat, bone, and cartilage cells. Benign lesions are most common, and primary bone malignant tumors are normally very rare. They only account for 1% of all adult malignancies and 15% of pediatric malignancies. As you know, the two commonest bone sarcomas are Ewing's and osteosarcoma, where osteosarcoma generally occurs around the knee and away from the elbow, that is your proximal humerus and radius, whereas Ewing sarcoma targets the flat bones in the body. And these tumors usually present with either pain, which is an organic pain, where you have pain at night and at rest, or they may have a mass effect, they present with swelling, or it may be an incidental finding on X-rays, or they may have neurological manifestations, especially when they involve the spine, or these patients may present with pathological fractures, which is around 10%. Histologically, we can grade them into low grade and high grade. Grading generally tells us the biological aggressiveness of these tumors and the likelihood of them to metastasize. As you know, sarcomas generally spread through blood, and all the blood is filtered in the lung. So that is the first place that you will find a metastasis. But we have the right to left shunts. So some of the blood does not go to the lung and goes directly into the left side of the heart. And the next place that it gets embedded in is the bone. Because when the vessels, the nutrient arteries enter the bone, they are endarterioles. They go through the bone sinusoids, and the bone sinusoids are the one that act as a filter to these tumor cells. And generally, when you find metastasis in primary bone sarcomas, they normally occur at the areas of the red marrow. Okay, so this slide shows the difference between sarcomas and carcinomas. When you're talking about sarcomas, you must understand that these are mesenchymal tumors, whereas carcinomas are epithelial tumors. Sarcomas spread through blood, whereas carcinomas spread through lymphatics. Sarcomas mainly go to the lung and bones, whereas carcinomas go to the lymph nodes. Sarcomas are heterogeneous tumors, whereas carcinomas are homogeneous tumors. And sarcomas, when they grow, they push the normal tissue to a side and cause condensation of the normal tissue, which forms a pseudocapsule, whereas carcinomas, they do not have a capsule. So when a patient presents to us, the first thing we need to do is staging. Staging is a process of determining the local and systemic extent of the disease. So the local extent of disease is generally done via MRI, where we are able to see the relationship of the tumor towards the neuromuscular bundle and the intramedullary involvement of the tumor. And the systemic staging is CT thorax, because we know that majority of them metastasize to the lung. And another one is bone scan to look for bone metastasis. And now most centers have opted to do PET scan, which with a high definition CT, where they're able to cover both staging investigations in one investigation. After you have done your staging studies, then we proceed to do a biopsy, because the biopsy with MRI of the local limb, we are able to determine the best place to do a biopsy. You must realize that sarcomas are heterogeneous tumors. We have areas where there is live tumor, and there are areas that are necrotic. So with MRI, we are able to determine the best site where we are able to get a representative sample of the tumor. And after the diagnosis, these patients are generally started on neoadjuvant chemotherapy. After neoadjuvant chemotherapy, then we proceed to surgery, which we'll be talking about, and followed by adjuvant chemotherapy after the surgery. So Enneking in 1983 came up with this compartmentalization concept, where he says that sarcomas, when they grow by within the compartment, pushing all the normal tissue to a side, and the anatomical structure forms a natural barrier towards the tumor, such as the muscle fascia, aponeurosis, deep fascia, and intermuscular septum. And according to the Enneking staging, he has made it very simple. He has staged it into 1, 2, 3, where 1 are all low-grade tumors, 2 are high-grade tumors, A is intracompartmental, B is extra-compartment, where they have moved more outside one compartment to involve another compartment, and 3 involves any form of metastasis. Once there's metastasis, it's already 3. So most of the patients that present to us are B. They are normally involved more than one compartment because there's always a break in cortex and soft tissue involved. So how does a sarcoma behave? It normally grows centrifugally, that means from center to out. It respects anatomical barriers. It takes the part of least resistance. And at the later stage, when the compartment is unable to contain the tumor, the compartment may break and it may involve more than one compartment. So what do we mean by centrifugal growth? That means the most mature cells are in the center of the tumor and the least mature cells are in the periphery of the tumor. And therefore, the tumor is heterogeneous. So when the tumor grows, it will grow by pushing the normal tissue, and outside the tumor, you get like a pseudo capsule, which consists of the condensed normal tissue and the inflammatory zone. Some certain concepts we need to understand is the concept of skip metastasis. Skip metastasis is the presence of tumor within the same anatomical compartment, but it is detached from the primary tumor. And natural barriers. As we know, cartilage is a good natural barrier. So your growth plate acts as a good natural barrier towards the progression of tumor. Therefore, you know that like in osteosarcoma, most of them occur in the metaphysis of the bone. And your facial plate in children acts as a barrier. Therefore, we are able to do a facial sparing surgeries nowadays. Or articular cartilage acts as a natural barrier towards the progression of the tumor. And you see, majority of our cases the tumor does not extend into the joint. But you can get joint involvement through 3 mechanisms. That is spread through the pericapsular, through the capsule. There's a pericapsular spread. Second is a direct spread through the fractures. It fractures into the joint and you spread into the joint. Third is through your ligaments, your cruciate ligaments into the adjacent bone. Therefore, when you do an MRI of the particular tumor, you must always involve the joint above and below and slightly above beyond the joints to see whether there's involvement of the other end of the bone. And for sarcoma, the indications for limb salvage surgery is we must get local control of the lesion must be equal to an amputation. That means if you do an amputation and you do a limb salvage surgery, the local control should be the same. Second one is the limb that you have salvaged should be functional. If you salvage a limb and it's not functional, you might as well opt for amputation. And amputation is generally performed when limb salvage surgery leaves inadequate resection margins. That means you're not able to get clear margins to gain local control. Second is resection leaves the limb useless. That means you end up with a non-functional limb. So therefore, it's better to amputate. So when we do limb salvage surgery, it's important for us to assess margins because surgical margins are important for local control of the disease. So the first way we can assess surgical margin is via MRI, where we look at the MRI and determine the local extent of the tumor, the intermedullary extent of the tumor, and the edema that is present. The area around the tumor that is edematous is actually the reactive zone. And in cases of osteosarcoma in Ewing's, when you give neoadjuvant chemotherapy, this edematous area tends to shrink. So a pre-operative MRI will help you determine the actual boundaries of the tumor. For Ewing's, it is said that we can use the pre-operative MRI as a guide to determine our margin. But for osteosarcoma, it's not proven. Therefore, we have to use the initial MRI as the guide for the margins. We cannot use the pre-operative MRI as the guide for the margins. And the second way is to deter intraoperatively. When you can feel grossly the tumor, make sure you remove it with a cuff of normal tissue. And if you're unsure, you can arrange for frozen section and take samples to determine whether the tumor is present or not in certain margins. And post-operatively, of course, we have to mark the tumor and send it for histopathology. But what you need to remember is that the moment the tumor is out, what looked like a 1 centimeter tissue around your tumor will shrink and will become just a few millimeters. So when the histopathologist report in their report that this tumor is 0.2 centimeter or 2 millimeters from the margin, you must take it with a pinch of salt, because you must realize that in real life, it is actually more than that. It's just that when you remove the tumor, all the tissue tends to shrink. So surgical margins can be divided into intralesional, marginal, wide, and radical. So this is a diagrammatic representation of what I said just now. So for intralesional, we go into the tumor and remove it. So the local, this will give you 100% local recurrence. And you are leaving behind pseudocapsule and macroscopic tumor. This is ideal for incisional biopsies of benign lesions or procedures such as Curettage for giant cell tumor and ABC, but it's not ideal for sarcoma surgery. Second is marginal, where we go in and remove at the pseudocapsule or reactive zone. In this case, you are leaving behind microscopic tumor. The rate of local recurrence is between 25 to 50%. Third is wide resection according to Anneking, where you remove the tumor with a cuff of normal tissue, where the local recurrence rate is less than 10%. Finally is radical, where you are removing the tumor with everything inside the compartment, including the neurovascular structure. That means you remove all the muscles from the origin to the insertion with all the contents of the compartment. As you can see, the mobility in this kind of cases is great. And you may say that amputation is a radical surgery. Amputation need not be a radical surgery according to Anneking's classification. Because if you have a tumor that is in the thigh and a distal thigh, and you do a above knee amputation, a high above knee amputation, it is still a wide resection, not a radical surgery. If you have a tumor within your calf or tibia and you do an above knee amputation, then it's considered as radical because you remove the entire compartment. If you have a tumor in the thigh and you do an external hemipelvectomy, it is considered a radical surgery. So this is the last slide. Before we end, the Japanese Orthopedic Association came up with another classification. Now it's known as the Kawaguchi classification, where they actually measure the length of the normal cuff or normal tissue around the tumor. This is based on malignant melanomas. It is good to read and understand this classification, but we generally do not use this for practical use because it is impossible for us to get those margins. But the principle of the classification is important, where they say that certain barriers represent certain thickness, like cartilage. Thick cartilage can represent up to 3 centimeters of margin. Thank you.
Thank you, Professor Vivek, for that excellent talk. I know it's very difficult to cover this topic in 10 minutes, but you did a great job. Is there any questions in the chat box? So, okay. Dr. Vivek, I have a very basic question for you.
Yes.
When we are planning to excise the tumor, as we mentioned in most of the malignant tumor, we prefer to get a wide margin, that is a wide local excision. That's how we plan the tumor. So a lot of my orthopedic colleagues ask, can we go near the tumor and see where the tumor and plan our surgery during the intraoperatively, or you plan based on the MRI pre-op and then do the resection?
It is very important to plan the surgery pre-op based on the MRI, because you need to be ready for what is coming. And you must, this is especially true in soft tissue sarcomas, where you find that there is a lot of edema around the tumor, and sometimes the edema extends along the facial plane, and is something what we call a tail sign, where it looks like a tail of a rat. It goes between the facial planes. So you need to remove this area because when local recurrence occur, it usually occurs at these areas. So
there is one. Yeah, thank you. There is one more question on the chat box. Dr. Ashish wants you to answer. What are the indications for amputations in these sarcomas?
The indication for amputation is when the tumor involves the neovascular bundles, and you know that post resection, the function of the limb is not going to be as good as a limb salvage surgery. So you should amputate these patients. Second is you can consider amputation in patients who have extensive disease, extensive metastatic disease, because you want them to proceed on with the treatment, continue on with the treatment as soon as possible for prolongation of life.
Okay, so one more question. The question is indication of rotation plasty.
Rotation. You can do rotation plasty for cases where the neurovascular bundle is not involved, especially when the nerve is not involved. But generally, we reserve rotation plasty for the very young children who are 6 years and below, where you know that any form of limb salvage surgery would account for multiple surgeries for them in the future before they reach adult size. One. Second is for tumors that are circumferential, but sparing the neurovascular bundle, especially the nerve, because the vessel can always cut and re-anastomose the vessel. But if we sacrifice the nerve, even if you reattach the nerve, the regeneration is not good enough for function.
Okay, thank you so much, Professor Vivek. So now we'll move on to next talk. So it is by Badira. She is a pediatric oncologist from Tata Memorial Hospital, and she is going to talk about role of chemotherapy in malignant bone tumors.
Yeah, thanks, Suman. So I think I'll share my screen. Let's start. I guess it's visible. Okay. So
make it full screen.
this is I have made it full screen.
Oh, now it's full screen.
Okay. I think there's a lag. Sorry for that. Okay. So what I'll do, I think I've been given 10 minutes. So I will not be able to walk you through. So I'll just run you through as fast as I can. So this is mainly, I should take a PS before this. I'm a pediatric oncologist, so mainly I'll be concentrating on osteosarcoma and Ewing sarcoma in my presentation. Even though you can have a quite handful of malignant bone tumors in children, adolescents, and young adults. So this is a skeleton which all of us have gone through when we have browsed Ewing sarcoma images through Google, and it represents the incidence and of the sites of Ewing sarcoma as well as the metastasis. I'm not going to talk about this. I'll just give you a brief background of Ewing sarcoma. Over the decades, several collaborative trials have actually improved the outcomes of Ewing sarcoma. When you did only surgery, the outcome was nothing more than 10 to 20%. But with the introduction of chemotherapy, the outcomes did improve to the tune of 50%. And over the last few decades, collaborative trials have actually fine-tuned the chemotherapy and outcomes for this tumor. And it is up to the tune of around 70% for localized Ewing sarcoma, and in certain cases of metastatic Ewing sarcoma, you have outcomes up to 40 to 50%. So still there are subsets which have got a very dismal outcomes like disseminated metastasis and relapse Ewings. So we'll just go through who to treat and with what to treat. So this is basically the principles of management in a single slide. So you have to understand that Ewing sarcoma is a systemic disease. So even if you have a visible primary in a bone, it doesn't mean it is only there. So since it's a systemic disease, you have micrometastasis elsewhere too. And hence it is important that you treat all of this. That is where the role of chemotherapy is. So in Ewing sarcoma, what we usually do is we give chemotherapy in a neoadjuvant fashion, because that will give you time for your limb salvage, customizations, planning. It would make surgery or your local treatment later less morbid, and it will make it less vascular and so on. And also you have many prognostic indicators, like you can look at the histological necrosis and plan for the intensification later. So you give chemotherapy in a neoadjuvant fashion after around 4 cycles, or roughly around 10 to 12 weeks. You do your local therapy, which is either surgery only, maybe surgery and post-operative radiotherapy, or where surgery is not possible, definitive RT. So you don't have any head-to-head comparisons of the different modalities of local therapy. After local therapy, you continue with maintenance chemotherapy. So this in a conventional chemotherapy setting would last around 10 months. But with the current chemotherapy, around 6 months is what is required of chemotherapy. So you have NACT, local therapy, and ACT in a setting of Ewing sarcoma where you're going to treat. So this is the evolution. I'm not going to go. It all started with 3 drugs. Then you have the addition of another drug. Then you have intensification with anthracyclines, alkylators. And this is where we stood a couple of years back. You have the American approach, which is a COG. They use mainly 5 drugs, a VDC, vincristine doxocyclophosphamide, and then IFOS etoposide. They used it in an alternative fashion. So initially, they used it 3 weekly. Then after 12 weeks, they had local treatment and continued their adjuvant treatment. Now, across Europe, what they did is they gave 4 drugs together simultaneously in the induction in a single cycle. So that has vincristine, doxorubicin, ifosfamide, etoposide. They were given 3 weekly for around 6 cycles, and local treatment was done and continued on adjuvant. During this period, many other drugs have been added, which was looked into to improve the outcomes, but none has worked so far. So they tried different permutations with respect to the schedule. And this is an American trial where they decreased the cycle length from 3 weeks to 2 weeks. And what they found that in localized Ewing sarcoma, they got around 10% improvement in the outcome. So this was the basis of the last landmark trial in Ewing sarcoma, and which is currently actually undergoing analysis in the second arm too, the Euro-Ewing 2012, which compared these 2 regimens of European and the American protocols, where 4 drugs versus 5 drugs which was given, and the American where it was given 2 weekly rather than 3 weekly. And the outcomes, as you can see, there was some improvement in the outcomes in localized and metastatic disease when they decreased the cycle length from 3 weeks to 2 weeks. Now, currently for localized Ewing sarcoma, interval compressed, that is 2 weekly VDC and IE, which is given in an alternative fashion, is the standard of care chemotherapy in localized Ewing sarcoma as well as metastatic Ewing sarcoma. And this has shown to have the best outcome in the contemporary era. Now, addition of whatever agents which has been tried in different trials has not improved outcomes to date. So apart from that, I have to say this is a chemotherapy which we follow in TMH, is an in-house indigenously developed protocol known as EFT 2001 protocol. Again, this is based on the idea of dose intensity of ifosfamide and doxorubicin, but this is given 3 weekly. So you have like couplets which are given alternatively. You have 2 cycles of ifosetopo, then 2 cycles of doxorubicin and cyclophosphamide. This helps to maintain the dose intensity. And one thing, when we compare this with the European and the American protocols, it has low cumulative doses of anthracyclines and ifosfamide, which would add to less late effects in this group of patients. We have only a retrospective audit. This is not a prospective audit of outcomes. And we do have in localized Ewing sarcoma outcomes to the tune of around 70%, and in isolated pulmonary mets outcomes to the tune of 50%. So this is a retrospective audit, which you have to keep in mind. So now, that is what in Ewing sarcoma, everybody needs chemotherapy, and it has to be given over the whatever protocol you use. You have to continue the full course of protocol. Now, I'm sure many of you would have patients coming to you to asking about the role of high dose chemotherapy with stem cell transplantation in the setting of an upfront Ewing sarcoma. To simplify it, currently there is no solid evidence of any benefit with high-dose chemotherapy with stem cell transplantation in an upfront Ewing sarcoma. The only subset where there may be some benefit, which was also not conclusively proven in the Euro-Ewing 99 trial, is the high-risk localized Ewing sarcoma who had a poor necrosis with neoadjuvant chemotherapy, or who had a high volume disease more than 200 ml at baseline. So these had around 10% improvement in outcome with stem cell transplantation, but the trial has to be taken with a pinch of salt. So that's the only subset which may benefit. Otherwise, if somebody asks you, if they can't, it is well and good, because you don't have to push anybody for high-dose chemotherapy in a setting of Ewing sarcoma. Now, metastatic Ewing sarcoma, 25% of Ewings are metastatic. Now, we should be actually prudent enough to identify those whom we actually want to treat. Now, isolated pulmonary mets is a subset you want to treat with chemotherapy and addressal of the primary as well as the metastasis. The outcomes are to the tune of 50%, 40 to 50%. If you have a residual met at the end of a neoadjuvant, and if it's resectable, you do resection and you administer whole lung irradiation. So this is some good outcome. You treat single bone mets. If only single bone mets are there, your outcomes with addressal of this mets also with RT is to the tune of around 30 to 40%. But anything more than one bone met, the outcomes are dismal, less than 15%. They actually would be better off palliated upfront. Lymph node metastasis also, addressal of the lymph node group, especially the regional with node dissection or EBRT, you have outcomes up to the tune of 50%. So you usually treat only limited metastasis, or maybe I can put it in a better way, a single system metastasis, like a lung metastasis only, or if it's a bone, a single bone metastasis, or you have lymph node metastasis. Disseminated metastasis have very poor outcome. Likewise, you may, in a relapse setting, who to treat. So the time to relapse is a very important factor, and late relapse is a set you can actually salvage with chemotherapy. And if they attain a CR with your neoadjuvant salvage induction, you can go ahead with local therapy, and they have better outcomes, but the outcomes are no more than 30% in a relapse setting. And the role of again stem cell transplantation in a relapse setting is very limited. The only subset who may benefit, again, we don't have solid evidence, is an early relapsed Ewing sarcoma who attains a complete remission after your salvage induction. Otherwise, there is no much role of high-dose chemotherapy in Ewing sarcoma. I'll just go through osteo again. Again, as I've said, in like Ewing's, osteo is also like a systemic disease. With surgery, the outcomes are only 10 to 20%, but with the addition of chemotherapy, it has improved to 50 to 60%. Now, whether you give chemo in a neoadjuvant setting or adjuvant setting, it doesn't change the outcomes. The outcomes are the same, but we tend to give in a neoadjuvant for reasons already defined before, because you can plan your salvage surgery, customize your prosthesis, you get make it less vascular and make surgery easy, and also prognosticate with respect to your histological necrosis. But I have to say, chemo alone has no cure in osteosarcoma. Your osteosarcoma, local and metastatic site, has to attain a surgical CR at some point, because mostly upfront only, because if it's not resectable upfront, unlikely that osteosarcoma would be resectable later. Both the local and metastatic sites have to be in a surgically, in a CR attainable site. Then only there is a point in curing osteosarcoma. So if you have a disseminated OGS, it's a multiple lung mets, it's better to palliate upfront. With respect to the chemotherapy in osteosarcoma, where do we stand? It has been shown in this analysis that when we have a 2-drug stem, the outcomes are up to 50%. You add a third drug, there is a 10% improvement. But addition of a 4th drug has not shown to improve outcome. So 3 drugs are better than 2, but 4 is not better than 3. So the usual are cisplatin doxo. Then you have a third drug, which can be a methotrexate, high-dose methotrexate-based regimen, or you can have a non-methotrexate. So there is no head-to-head comparison between MAP versus non-MAP. But in situations where non-MAP regimens have been used, the outcomes have been comparable to the one where they have used high-dose methotrexate. So you can choose as per your logistics and how you can administer high-dose methotrexate, because it requires admission and monitoring. Now, the most important prognostic factor, one of the most important prognostic factors, histological necrosis, as you know, and there have been trials which have tried to address the poor responders by intensifying intensifying chemotherapy. They have tried intensification in the neoadjuvant setting for patients and see whether it improves the histological responses, but this has not found to be any beneficial. Again, intensifying your adjuvant chemotherapy in poor responders and also modulating in good responders, this also has not shown to improve any outcome. So currently, we are with 3-drug regimen chemotherapy, whether it be a methotrexate based or non-methotrexate based. So this is what we follow in TMH currently, because administering high-dose methotrexate requires some supportive care and monitoring. This is OGS 2012. With this, the outcomes are to the tune of 50 to 54%. Now, what is the role of chemotherapy in relapse OGS? As I've said, in any setting of OGS, you have to be able to surgically clear the disease at the local site or the metastatic site. If you can't, we are not looking at a curative situation. It will be palliative. The role of chemotherapy in a relapse setting of OGS is not solid, but may be of some benefit. We tend to give in patients who have a TFI more than 1 year, who come with late relapses and who have been surgically addressed. The primary has been surgically addressed. So this is the only situation where we give some chemotherapy in OGS. Otherwise, the role is very controversial and it's not very robust. Yeah, so that would be it from me.
Thank you so much. Thank you, Badira, for the in-depth talk on the role of chemo in malignant bone tumors. Because of short of time, we'll have the questions in the discussion part where we go to discuss in detail about osteo and immune sarcomas. For postgraduate, what main thing you need to remember regarding chemotherapy is the role of chemotherapy is in osteo and immune sarcoma. So in osteo, the standard protocol we follow is chemotherapy, surgery, and chemotherapy. And in Ewing's, it's chemotherapy, surgery, and there is a role of post-op radiotherapy. Sometime where the surgery is morbid, we can go for definitive radiotherapy plus adjuvant chemotherapy. So we'll move on to next talk. So that is by Dr. Nehal Khanna. She is associate professor from Tata Memorial Hospital. So she's going to talk about the role of radiotherapy in malignant bone. Dr. Nehal, you are there?
Yeah, you need to enable me to share the screen. You will have to ask Dr. Badira to stop sharing, I guess.
Badira,
I'm not
please,
able to do it. I thank all of you, especially Dr. Ashish and Suman and Dr. Prateek for giving me an opportunity to be a part of this. Thank you so much. And I will now share the screen. Just give me a moment, please.
Thank you, Nehal, for sparing time for this. This is really helpful.
Always. It's really nice to be a part of this. Okay, am I able to? Yes. Okay, just give me a moment. Okay, am I audible and is the slide visible? It's in blue background.
Yes, ma'am. Please go ahead.
Okay, so I will talk on the role of radiotherapy in bone tumors.
Sorry to interrupt. Can you make it a full screen, please?
I have made it full screen. It
Okay.
is. I can see that it is. Is it not full screen?
No, it's not in the full screen.
Oh.
Slideshow. Can you go to the slideshow?
Yeah, I am on the slideshow. Is it still not? I can see that it is full screen.
No, it's looked like a editing mode of the PowerPoint. Maybe you just need to stop sharing and.
Yeah, I will stop share, and I'm so sorry for this. Okay, so I'll share again. Just give me a moment.
So meantime, it's difficult to answer all the questions. So what you can do is those who have any queries, post on chat. So we'll try to answer in between the talks.
Is it full screen now? Is the other slides moving?
No, it's not in full screen.
Still not. Just give me a moment. Just give me a moment.
Suman,
Yes, sir.
just I think Nehal needs to close
Just a
other
minute.
windows, open only this window, and then start sharing the screen. Then it will.
Okay.
Yeah.
Wait. Okay.
Ma'am, can you close all the windows? And
Yeah, I'm doing that right now. Okay, wait. Share screen. Okay. Press window. Absolutely.
Press that.
Press that.
Pressure.
Press share.
Well, your IT technician is there on board.
Absolutely. You are not seeing a 7-year-old helping me out. That's better. He's at least 12-year-old who's helping me.
Yeah.
So are you able to see it?
No, not.
This is surprising because
They should be able to see it. Huh?
Should be able to see it. Okay, again, stop sharing. Otherwise, my presentation is there
Should have started right
with
now.
Yeah, Pratik, can you open her presentation? Pratik?
Maybe it's on power.
Pratik, are you there?
Hello. Yeah, I'm trying. Otherwise, ma'am can just zoom in and start the presentation.
Yeah.
Just make the slides bigger, and I think we can just scroll them.
Yeah. I mean, if you're not able to, please continue. It's okay.
okay.
Ma'am, try and press F5.
Okay. So can you at least see the slide? If not in PowerPoint full screen, can you still see the slide?
Ma'am,
Visible,
press
yeah. Please go
F5.
ahead.
Function key 5. F5.
Did that? No, it's not happening.
Okay. No problem. Please continue. It's okay. It's visible.
It's visible, and is it moving at least?
No, it is stuck actually. No, your slides are
I
not
don't
moving.
know why is it happening. I'm really sorry.
Nehal, you mail it to me. I will.
No, I have already mailed it to Dr. Pratik. He has it.
Yeah,
and
I'll try that, ma'am.
He can always share it. I'm really sorry for this. Share screen. Or if at least this is seen, I can just zoom it a bit and you'll be able to. I mean, we can do it this way. Is my presentation seen?
Yeah, carry
Visible
on.
now.
Okay, so in the meantime, when Pratik is working on it, let's start the presentation. So I will talk about the role of radiotherapy in bone tumors. When we talk about radiation therapy, these are high energy or mega voltage radiation, which damage the DNA, and the pathognomonic hit is a double strand break, which eventually leads to cell kill. When we talk about bone tumors, and their sensitivity towards therapeutic radiation, it's a wide spectrum. We have certain tumors which are extremely radio resistant, like osteosarcoma, chondrosarcoma, and run-of-the-mill soft tissue high-grade sarcomas. We have tumors which are moderately sensitive, like Ewing sarcoma, like rhabdomyosarcoma, and giant cell tumors. And we have aneurysmal bone cysts, which are quite sensitive to radiation. Radiation therapy is generally teletherapy, where the source of radiation is a little far from the body, and brachytherapy, which is generally used in soft tissue sarcomas. And here it could be used in skeletal, non-skeletal Ewings, not that much of use for skeletal sarcomas. When we give radiation, you can see that graph which is there on top right. It is showing that when we give radiation dose to the tumor, we inadvertently deliver some dose of radiation to the adjacent normal tissue. And with better techniques that are available right now, we can reduce this dose to the adjacent normal tissue and keep it within very much within their tolerance to that kind of radiation. The different type of radiation that we give is preoperative radiotherapy, which is essentially given before surgery to make the tumor amenable to a margin resection, margin negative surgery. We give definitive radiotherapy when radiotherapy alone is a local treatment. We give adjuvant radiotherapy, which generally takes care of micrometastasis left behind after surgery, and obviously extracorporeal radiotherapy. And radiation with respect to malignant bone tumors remains an integral part of their multidisciplinary management. I will first start with Ewing sarcoma, and Dr. Badira has nicely covered the chemotherapy for Ewing sarcoma. The preferred local therapy for Ewing sarcoma remains surgery, but definitive radiotherapy is considered as local treatment in unresectable inoperable tumors, which generally happens in sites where surgery is going to be extremely morbid, like sacrum, head and neck, vertebra, calvarial bones, ribs, and chest wall. The other indications are when the surgery is feasible, but is going to be extremely morbid or can have an unacceptable orthopedic outcome, or if it mandates amputation and the patient is not willing for amputation. In certain cases of metastatic Ewing sarcoma, also it can be considered for local treatment. When we look at the outcomes, and we do not have a head-to-head comparison between surgery and radiation, but when you see this table, you can see that there is almost 15 to 20% reduced local control or increased local failure rate with radiotherapy. But we have to understand that these are all retrospective series, and there is definitely a selection bias. Smaller tumors, surgically amenable tumors are obviously considered for surgery. And when this is not feasible, larger tumors who haven't responded that well to chemotherapy are referred for radiation. And there are again certain sites like vertebra where it is difficult to deliver curative doses of radiation also, which makes the outcome a little inferior. But in general, radiotherapy is considered an inferior option, as these patients, we know Ewing sarcoma patients are young patients. The bones are still growing, and radiation, if you give now, if the child survives long enough to develop functional compromise. There is also fear of late local recurrences and second malignancy because of radiation. So local treatment has been, and in almost all studies, an individual treatment decision. It is to be decided in the multidisciplinary joint clinic. Now I'll show you a classic case that is referred to us for definitive radiotherapy, a sacral PNET, where the disease is extensive. It was involving the entire sacrum, and the standard doses that we generally use are 55.8. And after our radiotherapy dose escalation study results that have come out, which have shown that local control is significantly better when it comes to escalated radiotherapy. So the doses that are given in escalated radiotherapy, this radiation dose is given to the residual disease and not to the pre-chemotherapy extent of the disease. And the doses are given almost up to 70 gray, 70.2 gray. We have to now understand that whenever we give this high dose of radiation, what we need is conformal radiotherapy and image-guided delivery of radiation. These are the sites where we frequently give definitive radiation: the pelvis, the chest wall, head and neck, spine, and paravertebral disease. I will now talk about adjuvant radiotherapy in Ewing sarcoma. Again, it is a matter of debate, and every single case that requires at least a discussion of adjuvant radiotherapy should be discussed in multidisciplinary joint clinic. So we weigh the risk versus benefit of adding adjuvant radiotherapy. So in obviously cases of marginal resection, yes, post-op RT is required. Can post-op RT be omitted after marginal resection if there is complete response to chemotherapy? It has been seen, especially in the Euro-Ewings 99, that post-op RT showed a maximum benefit in patients who had 100% necrosis after chemotherapy. Intralesional resection, post-op RT is indicated in all cases, but if we know that this is going to be a planned intralesional, definitive radiotherapy is recommended in such cases. post-op should be considered where we feel that there has been a contamination because of previous biopsy and fracture, as the chances of microscopic disease which can lead to local relapse is high. So is there a threshold? Some institutes use 90, 99. It is very difficult to pinpoint or to give a ballpark figure of percentage necrosis rate. But after Euro-Ewing's 99, we know that even patients who have 100% necrosis will benefit with adjuvant radiotherapy. As I said earlier, radiotherapy is, Ewing sarcoma is a moderately sensitive tumor. So the doses that are required are between 45 to 60 gray. I'll come to this paper. Dr. Ashish and Dr. Ajay and Dr. Laskar have put in a lot of effort to compile this data of patients who received adjuvant radiotherapy in TMH. And it was seen that there was no difference in local control as well as overall survival when post-op was given or post-op was not given. And this paper actually emphasized that necrosis plays a significant role on impact. It's an extremely important paper, the Euro-Ewing paper, and all of us should read this, in fact, multiple times. Our understanding of Ewing sarcoma, how to deal with patients diagnosed with Ewing sarcoma, is improving because Euro-Ewings is coming up with multiple publications. These are the patients who are homogeneously treated, patients who have been prospectively evaluated. So this paper in particular, they used a robust statistical model, and 142 out of 159 patients received post-op, and post-op was as per the physician's discretion. And if you see this, after a median follow-up of 6.2 years, the local control, overall cohort local control rate was around 12%. There was statistically significant reduction in local relapse in patients who received adjuvant radiotherapy as compared to patients who were offered surgery alone. And another important time, I'm emphasizing it the third time in this presentation, that the benefits seem to be more in patients who had 100% necrosis as well as large soft tissue at the time of presentation. This paper also emphasized that once a patient has local relapse, either it is an isolated local relapse or associated with systemic disease, the overall survival was dismal. And this emphasizes optimizing local control. And what are the ways of optimizing local control? Probably addition of adjuvant radiotherapy, or when patients are considered for definitive radiation, we should escalate the dose. And this is how we can optimize local control. This paper, Dr. Badira has already spoken about, where conventional chemotherapy with whole lung irradiation was offered to patients with pulmonary metastasis as compared to Boumel-based transplant, and it was seen that there was no difference. This is one paper you must read. This is a paper on metastatic Ewing sarcoma, and we have dissected all the evidence that was available. And this paper gives us very good insights on which patients should we treat with curative intent and which patients we should palliate upfront. And we obviously understand through multiple publications that have happened that response to neoadjuvant chemotherapy stays as an independent prognostic factor. Other indications of post-op are obviously calvarial bones and chest wall bones. What is the role of radiation in metastatic PNET? As a part of local therapy to primary as well as curative doses of radiation can be given to metastatic sites. Obviously, the number of metastatic sites should be less, otherwise we would compromise the marrow function. Lung bath plays an important role in patients who present with pulmonary metastasis, and obviously palliative radiotherapy in patients who have metastatic Ewing sarcoma. I come to osteogenic sarcoma, and in one line, if I was to say, the role of radiation as compared to Ewing sarcoma is much less. As I said, osteosarcoma is a prototype of radio-resistant tumor. So the role of radiation comes in unresectable osteosarcomas, especially at centroaxial sites and in patients who have had intralesional resection. As I said, these tumors are radio-resistant. it is important to understand that they will require higher doses of radiation. But this higher dose of radiation to deliver, it becomes challenging because proximity to critical normal structures. If I talk about adjuvant radiotherapy in Ewing sarcoma, there is no evidence in support of role of adjuvant RT in osteosarcomas, but it is recommended in cases of margin positive, though I again would like to mention that there is no evidence in support of adjuvant RT. Chondrosarcomas, again, are prototype of radio-resistant tumors. They are slow-growing malignant tumors. Complete resection, that is surgery, is the mainstay of local treatment. But certain sites, again, sacrum, centroaxial disease, base skull, become surgically challenging. And in some cases, the tumors, if they are multiply recurrent, there are some reports which mention that there could be a role of adjuvant radiotherapy. We also have to understand that chordomas, they are so radio resistant that RT alone, when I say RT alone, it is photon-based conventional radiotherapy alone is unlikely to eradicate chordoma, and hence higher doses of radiation are required. When I say higher dose, you obviously need to use conformal radiotherapy and image-guided delivery of that radiation. Because they are resistant, there is a role of particle therapy, be it proton or carbon ion or other heavy ions. We know that when heavy ions, because of their sheer weight, once they attenuate, they deposit that energy and do not have something which is called as exit dose. That means the proximal, critical, normal tissues will not receive the kind of dose that is received by photon radiotherapy. And hence, carbon radiotherapy becomes one of the preferred modalities of treatment of unresectable chordomas. Other thing is, the biologically equivalent dose of particles is much higher than photons, again, by virtue or by function of their mass. Radiotherapy plays a role in aneurysmal bone cyst if they are inoperable and unresectable, and the doses that are required is moderate, 25 to 35 gray. For giant cell tumors of bone, again, the surgery remains the mainstay of treatment, but radiotherapy is offered to certain cases where it is multiply recurrent or surgery is not feasible. The radiation dose that is required is around 45 to 55 gray. And here I would like to mention that this kind of a dose, even at extremely critical location like pelvis and base skull, is not that difficult to deliver. These are photographs of some cases that we have treated. Obviously, all of you know about extracorporeal radiotherapy, wherein a very high dose of radiation is delivered to diaphyseal tumor. When I talk about sequelae of radiotherapy, we need to understand that grade 1 and grade 2 sequelae of radiotherapy are common, but grade 3 and grade 4 sequelae of radiotherapy are less than 5%. The common toxicities that we see are limb edema, fibrosis, subcutaneous necrosis. Sometimes we can have wound complications. There is also radiotherapy-induced fractures or insufficiency fractures are also known, but obviously the cause of these fractures, it's multifactorial. And radiation-induced second cancers, we have a lot of data on survivors where they talk about radiation-induced second cancers. But when I talk about certain tumors like Ewing sarcoma, we have this paper by Kutesh et al., which was published in JCO, wherein there was no incidence seen below 48 gray. So the dose of the probability of having a radiation-induced cancer increases with the dose that is delivered. I would like to thank you, and I'll be happy to take any questions if at all they are in the chat box. Should I stop sharing, Dr. Suman? Hello?
Yes,
Yeah,
ma'am.
please.
Yes,
Yes, madam. Please, Vishnu, you can start sharing your PPT. By that time, I have a question to Dr. Nehan. So you mentioned very clearly that the role of radiotherapy is maximum in Ewing sarcoma because they are radiosensitive tumors. So my question is, if the case is inoperable, for example, is Ewing's in the sacrum or in the pelvis, would you like surgeon to debulk it, remove 70-80%, and then send it to you for RT, or would you like to treat with definitive ORT without any surgery.
No, that is definitely not recommended. A debulking surgery in Ewing sarcoma is definitely not recommended, because even if you leave some disease behind, the dose that we will have to give will be full dose. And imagine the patient will have to bear morbidity of 2 different local modalities. So in such cases, it is always recommended that patient is referred for definitive radiotherapy.
So thank you so much. So the take-home message is,
so much for that question.
Yeah, if it's operable and if you feel that you're going to get good margins, then better to go and operate. Otherwise, directly refer the patient for radiation oncology. So thank you so much, ma'am. So we will move on to the next session. That is a panel discussion. Dr. Vishnu is moderating it, and I am 100% sure that he is going to make it very interesting and entertaining. Thank you so much, Vishnu. It's all yours.
Thank you to the organizers for giving me this opportunity. We have seen a surgeon, a medical oncologist, and a radiation oncologist try to kind of collaborate so that we can decide on the treatment of these malignant tumors. So we are going to try to put whatever they have spoken till now in a case-wise basis and discuss these case scenarios on what would be the ideal management of these patients. So we'll quickly get moving. So the first patient is a 17-year-old female who is complaining of pain and swelling in the back of the knee for the last 6 months. These are the radiographs at presentation. Dr. Navneet, would you like to comment on the radiographs?
Yeah. So it's an APM lateral view of the distal femur with the knee. And I can see a lesion in the posterior aspect of the distal femur. You can see a large soft tissue shadow in the first X-ray here. Yeah, exactly, the posterior one. And I'm not sure if there is any scalloping of the posterior cortex. I'm not sure if it's because of the screen here, but could be a scalloping there. Yeah, there is a lysis also seen in the AP view. Yeah, it's definitely something locally aggressive lesion.
So Dr. Navneet, what would you do to image next?
Yeah, I would get an MRI of the full length of the femur with the hip and knee joint with the proper tumor protocol and with the contrast, preferably with the contrast.
So Dr. Rajat, I'll come to you. What is this MRI tumor protocol, especially for malignant tumors, and what does it involve and why is it important?
Well, the tumor protocol, we have to scan the whole bone because we have to rule out any skip metastasis if at all. Number one. Secondly, we must get plain T2 sequences because that gives us a clear idea of how the lesion is inside. And then ideally we should also get a contrast imaging done because so that we get to know that what is the uptake like. We can differentiate between the solid and the cystic lesions, and that also give us some idea as to which part of the tumor we need to biopsy, because we would like to avoid a part which is more necrotic so as to attain more tissue.
So Dr. Srimant, would you please care to describe this MRI?
Yeah, hi. So basically we've got an MRI in an adult with a pretty large soft tissue mass, which has Navneet had shared, impinging on the vessels, probably even say more than 180 degrees of pushed across the vessels. And there seems to be involvement of the medullary canal also in the posterior aspect. You had showed us sagittal. Can you just put that, please? Yeah. So definitely, yes, there's no direct breach on the 2 planes, but on the axils, you can see that the tumor seems to have an epicenter probably in the cortex or the periosteal area with an involvement of the marrow canal and also a big posterior soft tissue. So definitely, yes, I'm looking at an aggressive sarcoma here.
What would be your next step in this management? You feel now, to summarize, on the basis of the imaging with both the X-ray as well as the MRI, we are looking at a probable aggressive appearing lesion, which is involving the metadiaphysis of the distal end of the femur. Looks like a primary bone tumor with a large posterior soft tissue component.
Yes.
So what would be the next step in the management, Dr. Srimant?
Next step is that definitely I would like to have a tissue diagnosis. So I would like to do a minimally invasive core biopsy.
So Dr. Abhijit, would you recommend doing an open biopsy or you're happy doing just needle biopsies?
Yeah, good evening. So genital biopsy is good enough. So we commonly do needle biopsy. So open biopsy is rarely recommended. If you get some negative working on J needle once or twice or thrice, then go for open biopsy. So J needle biopsy is good enough for this case.
Absolutely right, Dr. Abhijit. It is very important that we do not do open biopsies. We tend to do needle biopsies, especially with the MRI. We can target which is the solid area around the periphery of the lesion where you can get maximum tissue. You can also take biopsies just from the soft tissue component here, like this, where the soft tissue component is there, where you can just sample the soft tissue without even entering the bone, and you get accuracy rates with a needle biopsy of around 95%. And open biopsy is only indicated if multiple needle biopsies and image guided biopsies have come negative. So this patient was biopsied, and it has come as a Ewing sarcoma. So my next question is to Dr. Abhijit again. Sir, for an Ewing sarcoma, do you think that immunohistochemistry is mandatory, or you're just happy with a histopathological diagnosis?
No, IHC will be required by a pathologist.
And why is that? Why is it, sir? Why is it important?
So there can be two differentials which can help to differentiate it. So lymphomas can be there, small round blue cell tumors are there. So IHC will be helpful.
So this is another thing I want to tell all the postgraduates. In Ewing sarcoma, it is very important that we do the immunohistochemistries, because Ewing sarcoma belongs to a group of tumors known as small round cell tumors, which also includes rhabdomyosarcomas, lymphomas, etc., which have got completely different treatment. So an immunohistochemistry is now, in this day and age, is mandatory for diagnosing an Ewing sarcoma. The next question is to Dr. Navneet. Dr. Navneet, now we have got a
Vishnu, sorry to interrupt. Professor Vivek is also there, so you can involve and take his opinion.
Yes, yes, sir. So, Professor Vivek, sir, we have got now a diagnosis of Ewing sarcoma. We have done all the relevant imaging. What would be the next step, sir, in evaluation of this patient? What staging investigations would you prefer in an Ewing sarcoma?
We generally order a CT thorax and a bone scan, but in centers that have PET scan, it's better to do a PET scan. Because when the oncologists want to start the chemotherapy, if you have done a PET scan, they can forego the bone marrow biopsy that they generally need to do according to the Ewing's protocol.
Yes, yeah, absolutely right, Professor. So for Ewing sarcoma, the current recommendation is to do a PET CT for staging. If a PET CT is not feasible, then a CT chest bone scan and a bone marrow aspiration should be done as staging. And it is very important to stage all these tumors, and there should be no starting of treatment without a proper staging investigation. So we went ahead and did a PET CT for this patient. So PET scan also showed the presence of lung metastasis, which were bilateral. So we can see lung mets here, and on the other side also there are lung metastasis. So my next question is to Dr. Badira. Dr. Badira, you had mentioned about pulmonary metastasis in Ewing sarcoma. What do you think is the prognosis for this patient? Should we offer curative intent treatment for this patient?
Yeah, so Ewing's, yes, if it's you're saying a single system metastasis, only isolated lung mets.
Yes, it is isolated pulmonary metastasis, no bone metastasis, no lymph node metastasis.
Yes, so we would give the intent of treatment would be curative, and we'll go ahead with NACT, then response assessment, and continue with the rest of the treatment and address the metastasis also. Yes, the intent is curative because they have good prognosis up to the tune of 40 to 50%. And the number of mets actually doesn't matter much, because around 60 to 70% of lung mets respond to chemotherapy, and you can see a good response after neoadjuvant.
So, Dr. Badira, my understanding is that you're using EFT 2001 protocol only for Ewing sarcoma currently?
Currently, we have we have not switched to COG, because 2-weekly dose strengths is a thing we have to look into with a lot of infections and cardiotoxicity we have seen in our EFT 2001 retrospective cohort also. So yeah, we are continuing with EFT as of now. We may look into the other one, yes.
My next question is also to you, madam. What would be the ideal time for local site therapy in an Ewing sarcoma? How many cycles would you want to give, or what is the ideal time when we can do the local site therapy?
So it's around 10 to 12 weeks. So it's around 10 to 12 weeks is when you have to do local therapy. So there are some studies, even from PGI also, even when we looked into our retrospective cohort also, a delay more than 16 weeks of any sort of local therapy has been shown to be associated with an adverse outcome. So this is on retrospective cohorts from both the institutions. So that's there. So around 10 to 12 weeks is the ideal time where you would address the primary with any sort of local treatment.
Absolutely, madam. So to summarize now what all we have done. So we have a patient who is having pulmonary metastatic Ewing sarcoma with a large volume disease involving the distal femur. Pulmonary only metastasis, so the intent of treatment is curative. So we are sending the patient for neoadjuvant chemotherapy with multi-drug regimen, which the patient receives. So these were discussed with by Dr. Badira, where we have used a whole host of chemotherapeutic regimens, and now currently the standard of care is to use VAC and IE. Now, it is also discussed regarding the local control in Ewing sarcoma by Dr. Nehal. So we will just get to this a little bit, but this is the post NACT imaging, where in the X-ray you can still see that there is a light shadow in the posterior side, and this is the post chemotherapy MRI. So, Dr. Navneet, would you care to comment on the post chemotherapy MRI, sir?
Yeah. So Ewing sarcoma, normally a good responding tumor, we would expect excellent shrinking of the soft tissues, and even on the contrast, you will not see a lot of contrast uptake post chemotherapy. But unfortunately, in this patient, looks like it has not responded very well. The soft tissue is still persisting. The soft tissue encasement 180 degree around the vessel is also still persisting. So doesn't look like a very good responder.
I would like to add here that when we got the PET CT done, the lung mets had completely disappeared. All the lung metastases which were previously there had disappeared. Does that have any bearing on your treatment decision making?
No, that's what we would still go ahead with the local control, and the local control would likely be a surgery. Definitely, I would prefer to add radiotherapy based on the margins and the necrosis. Yeah, the soft tissue is still persisting. This is not good. It still looks worrisome.
Okay, my next question is to Professor Vivek. Sir, what would you recommend now for local site treatment, sir?
For our center, we generally do a wide resection with endoprosthesis replacement. As you can see, the vessels seem to be on the outskirt of the tumor, and they are not within the tumor. So limb salvage is still possible, but prior to surgery, I would ask the oncologist if they can give radiotherapy first.
So you would have given option of pre-operative radiotherapy as well.
Yes, in attempt to shrink the tumor one. Second is to enable me to go and get closer margins, because the margins will be closest where the vessel and nerve is.
Dr. Nehal, what is your take on giving pre-operative RT for Ewing sarcoma, madam?
It's a very, very difficult question. Our understanding and in fact, the experience also says that the response to chemotherapy and radiation goes hand in hand. So if a patient or a lesion hasn't responded that well to chemotherapy, it's unlike that there has going to be a further response with radiation. But understanding that these are sensitive tumors, probably it will still have. So it can be considered, but I'll tell you one big problem with preoperative radiotherapies. You give preoperative radiotherapy, then you take a scan after a couple of weeks, and if you say that surgery is not feasible, now give the remaining dose of radiation. Now, giving that remaining dose of radiation after a gap of few weeks is, the radiation delivery then is considered highly suboptimal. So one option is that you deliver full dose of radiation, consider it as neoadjuvant radiotherapy, and plan surgery. In case if surgery is feasible, well and fine. If it is not feasible, at least with respect to radiotherapy, the local treatment is complete. I don't know how good or bad this thing is, but yes, this is what I know most of us do practice.
Madam, considering now that Professor Vivek said that he is probably thinking of doing a mega prosthesis, is there any wound complication difference between giving pre-operative and post-operative RT, madam?
Yeah, there would be. There would be, for sure there would be. So you have to be a little wary of having increased wound complication when neoadjuvant radiotherapy is given. But essentially the complication happens because of the tissue that is delivered to the subcutaneous region. When I'm not talking about prosthetic loosening and all, but wound complication with conformal radiotherapy would not be that much as compared to when conventional radiotherapy is offered. So if the doses to the skin and subcute are not that much, it can still be considered. But as I said, the rationale itself is not that strong enough to offer preoperative radiotherapy, and hence it's not that commonly practiced.
My next question to Dr. Srimant. Dr. Srimant, what do you think about the vessels? Would you be happy to dissect the vessels free, or would you consider a resection of the vessels, and would you consider this salvageable also?
See, one thing is the response, as Navneet showed, is that it is suboptimal. We are dealing with large, more than 200 cc volume lesion here with suboptimal response to chemo. I would still go ahead and try to dissect the vessels. I still feel it's possible, considering that we have a longer length of images available. It's not encased completely. So this patient will require a wider section, SOS, vascular reconstruction if any issue happens. But I think the vessel would come off, and definitely I would follow up this patient with post-operative radiotherapy.
So our post-NACT reassessment showed that there was some 20% reduction in size of the tumor, and all the lung mets had disappeared. So considering that all the lung metastasis had disappeared, we did continue offering curative intent treatment for this patient. We decided to do a upfront surgery because we were worried giving preoperative RT with regards to wound complications, especially when we are putting a prosthesis inside. So this is what we did. We went through a medial approach. We have isolated the vessels both proximally as well as distally to the tumor. In this case, we felt it was more prudent and wise to do a vessel resection for this patient because we couldn't dissect the vessel free. So the sheath was normally the vessels tend to pop out when you cut through the sheath, but in this case, we thought it was more prudent to do a vessel resection. So we clamped the proximal and distal end and removed the specimen along with the vessels. We reconstructed the bone defect with a tumor megaprosthesis. And after that, we have used a saphenous vein graft and reconstructed the artery also for this patient. And here you can see the specimen with the vessel which was encased completely inside the tumor. We have got good margins all around it. Now the final HP was suggestive of Ewing sarcoma. The necrosis was 40% and all the resected margins were free. My next question is to Dr. Badira. Dr. Badira, considering that she has only 40% necrosis, would you consider changing her chemotherapy, or would you alter anything in her adjuvant protocol?
As far as chemotherapy is concerned, we'll continue the same. So I think Nehal will do the rest of alteration.
So this is very important. Both in osteo as well as in Ewing sarcoma, we do not change the chemotherapy protocol based upon the necrosis. Even if the necrosis is less, there is no benefit of actually changing the chemotherapy in both osteo as well as Ewing. So you continue with the same maintenance cycles subsequently. My next question is to a surgeon, Dr. Rajat.
Dr. Vishnu, I have a question first to the medical oncologist. So if we have this kind of a necrosis, assuming patient was given 3-weekly protocol, do we have any evidence that shifting to 2-weekly protocol might help?
No, as such, no. We don't have a study with respect to that 3-weekly shifting to 2-weekly would help improve. So as far as this is concerned, most of this histological necrosis till now, especially in OGS, is a prognostic factor. It's not a predictive factor where any alteration in treatment has changed the outcomes when you know that this is bad. In Ewing, the only thing is a post-op RT where the post-op addition of RT has improved, but as such, any alteration in the schedule of chemotherapy has not yet. But this one, what you said, 3-weekly changing into 2-weekly has not been looked into. And I don't think there is any scope for that because currently 2-weekly neoadjuvant is the standard of care and nobody is going to do any alteration with respect to that. So the thing is, it's not been looked into.
Many centers,
sorry.
In many centers, patients are still given 3-weekly regimens.
Yeah.
So that's why I was just asking. So if we
actually
come across a patient, who has received a 3-weekly regimen, and we then see this kind of a necrosis, and empirically, do you think it will benefit if we shift to 2 weeks?
I don't know. We don't have a definite answer for the because that has not been studied. But what I can tell you is that this thing is, I don't think it's going to change much because even if you look at 3-weekly versus 2-weekly, the benefit which has been there is only 7 to 8%. If you look at it, but you have to know that RCT was also in many of the patients, 1/3 couldn't complete the 2-weekly treatment. So it's not like a foolproof trial also, if you look at it in that way. And if you can adjust to the toxicity, that 7% improvement in outcome in our setting could be easily negated by the toxicity or the infections and the rest of the events that we are going to encounter. So it's not a very foolproof thing to adapt into. And this particular aspect, what you're saying, has actually not been evidence-based looked at. So I mean, I cannot give a conclusive answer, but I don't think it's going to affect much.
Okay, and my next question is to Dr. Abhijit. Dr. Abhijit, now you have got this as your final HP. Would you consider giving post-operative RT?
So post-op RT will be a bit tough in this case as vessel reconstruction is done. So need to go talk with our radiation oncologist that how comfortable they are with a joint and a vessel reconstruction. And would it help really in the oncological outcomes? If the percentage necrosis is less, vessel is reconstructed, would it add any benefit to it? So need to discuss with Dr. Nehal Madam. What is her opinion?
So Dr. Nehal, the surgeon has suggested that to take a radiation oncologist opinion, madam. What is your opinion on this?
So if you look at this case, this patient had large soft tissue at the time of presentation. This patient did not have that great response at local site with chemotherapy radiologically. And it is shown in the histopath also that the necrosis, the response is not that great. So first, we understand that the outcome is not going to be that good. Second, this patient is also at high risk for local relapse. But this patient has a prosthesis in situ. So again, I said, this is not one person's decision. We have to sit together, dissect every single point, and then take an MDT decision here. I would say that, yes, maybe we should wait for a little longer time, 6 weeks, 8 weeks before we start adjuvant radiotherapy. We should wait for the healing of the graft to become better. We should not hurry on to giving adjuvant radiotherapy. Probably in this case, we should err towards giving RT than not giving RT.
Exactly, madam. Also, I wanted to discuss with you. There were lung mets previously which was seen. Do those need to be addressed?
Yes, absolutely. I'm so sorry I missed that. Lung bath is an extremely important part of treatment of Ewing sarcoma patients who present with pulmonary metastasis. So we see two kind of scenarios here. One is the patient that you presented, patient who has had complete response to chemotherapy. So in this patient, we consider whole lung radiation. And in patients who do not have that kind of response, if they have 1 or 2 residual lesions, we send them to our thoracic surgical services for evaluation of surgical metastatectomy. In case if it is not possible, we do boost radiation to the nodule, the residual nodule, irrespective that patient receives lung bath also.
So this is a very important point to all the PGs. All metastatic Ewing sarcoma with lung only mets, even if the metastasis disappear on chemotherapy, they all are candidates for giving a lung bath, and that is shown to actually improve survival as well as local control in the lungs. So what we did is we started the patient 2 weeks after the date of surgery. We started the patient on adjuvant chemotherapy. We gave 2 more cycles of adjuvant chemo, and after 2 months, we started the patient on post-operative RT as well as lung bath was given for this patient.
Yeah, I have a question for Dr. Nehal.
Yes, please.
Yes, you said that you can give post-operative radiotherapy. Is there a time duration within which you need to give the post-operative radiotherapy?
Yeah. So ideally, it can be started once the wound heals. There is no, set cutoff that beyond this you cannot give, but it is seen that if you give beyond 12 to 16 weeks after surgery, the benefit that you would expect with radiation will, will reduce.
Yes.
So generally we don't give after, 3 to 4 months after surgery. But in this case, I mentioned that, we should delay, though I do not have any evidence to support that delaying will be better in this patient. But looking at the complicated surgery that has been done, we would want the healing to optimize before we start radiation. Otherwise, you'll all blame radiation oncologist for the wound complication and the prosthesis failure.
Okay.
Ma'am,
This patient,
just have a
we actually
small question.
waited 3 months. Yes, please.
Yeah. My
Yes,
question is to Nehal,
absolutely.
ma'am. Ma'am,
Yeah.
if all the nodules had not disappeared and if there were one or two nodules which were smaller but still persisting, would you reevaluate the lung lesions at the end of chemo or would you give a lung bath anyways now?
This is
If
a
there are one or two
very
nodules.
good. Yeah, so we know the timing of local radiotherapy. What we don't know is the timing of when we should offer radiation to the lung. What we generally do is, because of logistic reasons, we want to finish both the radiation together. But it can easily happen that if the response has not been that good, we would consider completing the entire course of chemotherapy, evaluate the lung, and then offer radiation. In a patient who has had complete response, I think it is worth the while to consider radiation while you are giving it to the primary site.
I think, but Nehal, especially this is because of bad biology disease. If you're going to give it a curative shot, you should give it
Agreed.
early because the chances
Early.
of
Absolutely.
a clone and
Absolutely.
progression is more. Yeah.
Yeah.
So just to summarize the indications of RT in Ewing's, the definite indications are positive surgical margins, inoperable disease, lesions in axial skeleton, poor histological response, and when you're giving lung bath for lung mets. Relative indications include presence of pathological fracture, prior open surgeries like a curettage or open biopsy, and large fungating mass at presentation. So this is what the patient's current status is. She is now 2 years almost post. She's 2 years post treatment, doing everything nicely and with no relapse at least till now.
That's really nice. Good functional outcome. Very good.
So we'll quickly move on to the second case. This is a 7-year-old child complaining of pain and swelling over the left shoulder for the last 2 months. Patient had an open biopsy done.
Vishnu, let's wrap up in 10 minutes. Huh?
Yes, sir. The patient came to us and was treatment naive. Examination showed a bony swelling like this with a large open biopsy scar. My question is to Dr. Rajat. Dr. Rajat, would you please care to read this X-ray? Dr. Srimant?
Yeah, so basically we've got a... Yeah, Vishnu, can you hear me?
Yeah, I can hear you, Srimant. Continue.
Yeah, basically we've got an X-ray, completely not full length, of an immature skeleton's proximal humerus in the shoulder. There's quite a bit of sclerosis here in this and a periosteal reaction, with a wide zone of transition. Is there a fracture around in the proximal humerus? Was there a history of trauma or anything?
There was an open biopsy.
Oh, open biopsy. Oh, that's pretty unusual part. So definitely, yes, we are dealing with something pretty aggressive. So, I would like to get that MRI done. And have they done the open biopsy without an MRI?
Yeah, they did the open biopsy without the MRI.
Oh, okay. That's great. So you must have got an MRI done with the contrast, right?
Yes.
Okay. That's again.
We'll
this
go
is
on quickly
again
to Dr. Rajat.
Yeah.
Dr. Rajat, can you just describe this MRI? I've shared T2 axial and T1 coronal, which is involving the full length of the humerus.
Well, yes, there is a large soft tissue component with the main vessels on the surface of the tumor, and the visualized distal humerus looks okay to me. So I would still consider the age is 7 years, you said, no?
Yes.
So I would consider Ewing's as my first differential here, considering the soft tissue component and the aggressiveness of the lesion.
But there's so much sclerosis on the X-ray.
Yes. But yes, it can be there. Now we can have some sclerotic variants of Ewing, but considering the soft tissue component, yes, osteosarcoma and Ewing's both are the differentials.
Yes. So this is very important. I want to tell this to all the postgraduates. Any sclerotic lesion in an immature skeleton should be thought of as an osteosarcoma unless proven otherwise. So it is always, even if you're suspecting osteomyelitis, unless it is blatantly seen with respect to a sinus or on imaging, but any sclerotic lesion should be thought of as an osteosarcoma, and a needle biopsy should be done and not an open biopsy. This is very important because very often you get cases where the operating surgeon has thought of as an osteomyelitis and gone in and done a curettage, which should not be done. So the MRI is done. We proceeded with a biopsy, and this was the biopsy slides, which shows a lot of spindle cells with bizarre nucleus, and you can see osteoid formation between these malignant appearing cells, and it was suggestive of an osteosarcoma. So my next question is to Dr. Navneet. Dr. Navneet, how would you stage an osteosarcoma? Is it different from an Ewing's, or would you be happy to do whatever you're doing for Ewing's?
Yeah. So compared to Ewing's, which can have marrow metastasis, for an osteosarcoma, we can actually do just a plain non-contrast CD thorax, breath holding CD thorax with a technetium bone scan, or a PET based on whichever is available at the institute. But a CD thorax with bone scan is as good as PET for an osteosarcoma.
Yes, that's a very important point, especially for the PGs. A PET may not be needed in osteosarcoma. We can get away with just doing a CT chest and a bone scan. And there are numerous studies which have actually compared both bone scan CT chest versus PET CT. So we did a CT chest and a bone scan, and the patient was diagnosed as non-metastatic. So my next question is to Dr. Badira. Dr. Badira, can we just operate this patient upfront, or is there a role of giving neoadjuvant chemotherapy in osteosarcoma also?
Yes, so that is I think your call, but this is a very big one. So what I have to say is chemotherapy is a must, and it's better to start with neoadjuvant. As you have rightly said, it has got a large soft tissue, and you have to plan your prosthesis, and your surgery will become easier if you give neoadjuvant. But whether you give neoadjuvant or adjuvant, what the randomized trials have shown is that you have to give chemotherapy, and it is majority of the time it's neoadjuvant only. So I think you can start off with chemotherapy.
So my next question is to Dr. Abhijit. Dr. Abhijit, would you consider operating upfront in an osteosarcoma, or do you prefer giving neoadjuvant from a surgeon's point of view?
So neoadjuvant, we'll start with neoadjuvant chemo in this case.
And why would you?
Very rarely we
of giving NACT
do upfront surgery. So a bleeding, fungating mass, that can be only few indications. So all osteosarcomas we give neoadjuvant chemo.
Yes, so it is very important to give neoadjuvant chemo in these malignant tumors. One, it might actually help to reduce the disease burden. It might help you improve the chances of you getting a margin negative surgery. And most importantly, you can assess the treatment response, which is a very important prognostic factor for survival. So we started chemotherapy. Now, as Dr. Badira had told in her talk, there are 4 important drugs, that is methotrexate, adriamycin, cisplatin, and ifosfamide. We try to give a 3-drug regimen, which may be either MAP or IAP. So our patient completed 3 cycles of neoadjuvant chemotherapy. We used the IAP regimen for this patient, and they had a good clinical response with significant reduction in pain as well as size. I don't have the post NACT MRI, but Dr. Rajat, I would ask Professor Vivek, sir, how would you like to treat this patient, sir? I'll just go back to the MRI. The child is 7 years old, and pretty much the disease was the same.
You mean there was no shrinkage in the tumor?
Yes, sir. It was like that only, but the patient had significant reduction in pain, and his function and all improved, sir.
Okay. Do you have the post-chemotherapy X-rays? Because in osteosarcoma, if the tumor is responsive to chemotherapy, it will solidify. The tumor will solidify, and you can see more ossification onto the bone itself.
Yes, sir. He had a good response, but I unfortunately don't have the post-chemo imaging.
Okay. As you can see, the vessels are out of the tumor. So I will proceed, for that age, I'll proceed and do a limb salvage surgery for him.
So how would you what would be a preferred reconstruction method, sir, in a child who is 7 years old?
Is 7 years old. The usage of endoprosthesis is out of the question. And usually for osteosarcomas, we normally don't do recycle autografts. The reason being is because even if you recycle it, the thing will still remain bulky, and we are not very sure what will the tumor necrosis rate be if you recycle the autograft. So here we will tend to use the allograft to reconstruct back this patient. For a 7-year-old, we'll probably use a duct fibula to reconstruct.
Okay, sir. I'll ask another surgeon, Dr. Rajat, what would be your preferred reconstruction method in a 7-year-old child?
Well, I would consider here using a fibula with growth plate transfer here, if patient has responded well to chemotherapy.
Yes, and the patient is non-metastatic also. Any other surgeon, Dr. Srimant, would you care to add any other way to you can think of reconstructing this?
See, for me, biologically, this is not a very good prognostic patient considering the tumor volume and the response. Even though the pain is gone, I would just probably, try to put a nail cement spacer or a suspension and just leave him, please. No fibula, no biological for me in this patient.
So I would like to tell this is very important to the PGs. So the way you resect it is actually very important. There can be numerous reconstruction options, but the resection should be on the basis of oncological principles where you are excising the tumor with wide margins all around. That is actually very important. Now reconstruction, when it comes to reconstruction, there are multiple options. So as you heard, 3 surgeons had 3 different opinions on reconstruction, and all of them are right in their own ways. So what we proceeded to do was we tried to do a wide margin on the basis of this paper by Kawaguchi. So here you can see that we have done a wide excision. This is the glenoid which is seen here. You can see the main neurovascular bundle here. The specimen is removed along with its biopsy scar. And we did a growing live fibula for this patient along with anastomosis of the vessel so that we could try to get some longitudinal growth along with the fibula. Here you can see the anastomosis of the anterior tibial vessel which supplies the growth plate. And we suspended this with by using a proline mesh from the glenoid. The final histopathology was conventional osteosarcoma with 50% necrosis and all margins free. Again, Dr. Badira, would you change the chemotherapy?
No.
So this is very important. You do not change chemotherapy on the basis of necrosis, even though you know that this patient is having a poor response, but still the chemotherapy remains the same. So this is the patient's function at 1.5 years. He is now 5 years post-surgery and he is doing really well. And there has been good longitudinal growth in his fibula as well. Just quickly, we'll go to the last case. This is a 60-year-old male patient complaining of swelling over the last 6 months with now difficulty in weight bearing. This was the X-ray which showed a kind of lytic lesion with well-defined margins superiorly proximally, which is involving the epiphysis and the metaphysis of the distal femur. It's got a kind of lobulated appearance on the X-ray itself. There is no bone expansion or periosteal reaction or soft tissue component. So my question is to Dr. Navneet. Dr. Navneet, what would you think this is on the basis of your X-ray? I'm also sharing the MRI images also with you.
Okay. Yeah. So the age you said?
Age is 60.
60, yeah. So anyone above 35 years of age, 35 to 40 years of age, I would think of a metastatic lesion first. And so I would evaluate for the site of the primary first. If there is no site of primary known after detailed investigation, then I would do a biopsy from this. This lesion, however, looks very aggressive. Though X-ray looks like could be an epiphyseal giant cell tumor, but on the MRI it looks very aggressive with some peripheral lobulations. So
this is a very important point. Any patient who is above the age of 40, the likelihood of a bone lesion being metastasis is almost 80%. So it is very important that you try to identify a primary in patients who are above 40 because that is the most common cause. Once you have ruled out a possible primary, the next step would be to then do a biopsy of the primary lesion. So as Dr. Navneet had suggested, this is an aggressive looking tumor in the epiphysis and a biopsy was done and it turned out to be a grade 2 chondrosarcoma on the biopsy. So my next question is to Dr. Badira. Dr. Badira, any role of giving chemotherapy in chondrosarcoma?
I think you people only can answer that. We don't see chondrosarcoma at all. Yeah. I'm a pediatric oncologist, so.
Yes. So chondrosarcoma, there is very limited role of chemotherapy in a chondrosarcoma, and basically it is treated only with surgical resection. One important point I would like to add, which is a published paper from the TMH group, where they suggested that for staging of a chondrosarcoma, a CT chest might be enough because the sheer incidence of bone metastasis in chondrosarcoma is extremely low. And they have recommended to do a bone scan only if the CT chest is suggestive of lung metastasis. So currently we are doing only a CT chest for staging of chondrosarcoma. My next question is to Dr. Rajat. Dr. Rajat, do you feel it could be something benign like an enchondroma, or you actually want to further investigate this lesion?
No. This is a highly aggressive looking lesion. There is a edema there, so it has to be. I agree with the biopsy report of a chondrosarcoma here.
Yes, so there are certain ways by which you can identify a chondrosarcoma from an enchondroma, which includes a size more than 5 centimeters, presence of endosteal scalloping, presence of a soft tissue component, which is seen here on the posterior side, and presence of cortical breach. So out of these 4, if any one is present, the likelihood of it being a malignancy is actually more compared to an enchondroma. So this patient, since there is no role of any chemotherapy in a chondrosarcoma, underwent a wide excision. This we have treated a little differently. We did a chevron osteotomy here in the proximal end. We took out the specimen like this. We ECRT'd the specimen, and because it was a small segment resection, we actually did a conventional total knee replacement with a long stemmed prosthesis. We tried to basically use it as a alloprosthetic composite, and then we put this entire thing back inside. So this is how it looked post-operatively. So you have got a good chunk of stem which is there above the osteotomy site, and we are hoping that with the chevron osteotomy this would actually unite. The advantage of doing this is that we are trying to retain the bone stock, and we are avoiding a mega process, and we are using a conventional revision total knee system itself. So this is the function and post-operative imaging of this patient. So you can see that the knee range of movement is really good. Patient's walking around well, and the osteotomy also appears to be uniting at 3 months. So I'd like to conclude here. We have done the 3 basic malignant tumors involving the bone, which is Ewing's, osteo, as well as chondro. So if there are any questions, I'd be happy to take them up, or the panelists would be happy to engage you.
Okay, thank you, Vishnu, for this case discussion where you covered the most common malignant tumors which we see in our practice, and also for the panelists to making it interesting and giving all the details which is required for our postgraduates. So next we have our quiz for our postgraduates. So
just one sec.
Yes, sir.
Yeah, I think it was a very, very interesting session, and I sincerely want to thank Dr. Suman Bairegoda for doing all the hard work. I'm just guiding him, but he's the one man behind this entire webinar. Thanks to you. Thanks to our speakers, especially Professor Vivek Ajit Singh, who's still awake at very late in the night, and have ensured that the information regarding the webinar reaches everywhere in Malaysia and Asia Pacific region. Thanks to the speaker, Dr. Badra and Dr. Nehal, who, as usual, have done a great job. And Vishnu, you were on spot today. And thanks to all the panelists. Thank you so much. And now, please don't go away. We have this interesting quiz coming up, and I'm sure Pratik and Suman will take you through this very interesting part of this webinar. Thanks.
Thank you so much, sir. So once again, I like to thank all our panelists. I just forgot to introduce them because of short of time, but all of you guys are so well known in our country and also outside for the great work you guys are doing. So thank you so much for all the panelists and Professor Vivek, Dr. Nehal, and Dr. Badira for being part of this. Thank you so much. So don't go away. We have a very interesting quiz. Pratik has kept few interesting questions. I think 10 questions we have. They are really interesting and informative. So please stay with us.
Thank you, everyone. That was a very interesting discussion. I hope you can see my screen.
Yes, Pratik, please.
Yes. So, as you know, this quiz is for postgraduate students and young orthopedic consultants. The panelists can join for fun, but the prize money is for the participants or the delegates only. Now, the rules of the game are simple. You download this app called as the Kahoot app and you play on the mobile. This is the game pin that you have to enter in that app and you will be able to participate. We have had a wonderful session where Professor Ajit Singh, Nehal ma'am, Badira and Vishnu sir had a fantastic discussion. So that will help you in solving these quizzes. So before we go ahead to the main quiz, what we'll have is a practice quiz. This is for the participants who have not seen or played this Kahoot app before. And it is for their understanding and for their enjoyment. So we have quite a few numbers. We are having around 60 to 70 participants. So I'm expecting at least half of them to participate in this final quiz. Before we go ahead, we'll have the demo quiz. Now, please remember, you have to answer correctly and quickly. And the points is dependent on how quickly you answer the correct answer. So this is the game pin for the demo quiz. So I'll just go ahead with the demo quiz with your permission, Suman sir.
Sorry, Pratik, I missed.
So we'll just go ahead with the demo quiz first, and then we'll add the main quiz.
Sure.
Yeah.
Yes,
So the game pin is 7708030, and we need to download this app for you to be able to play. So this
So
is
if
just
I'm
a
not
demo
wrong,
quiz.
we have 17 participants, right?
Okay, this is the demo quiz, sir. Yeah. So
Okay.
we just play so that they can understand how to play it.
Okay.
So the first question of the demo quiz: who is the Prime Minister of India? Is it option red, Amit Shah? Is it option blue, Draupadi Murmu? Is it option yellow, Narendra Modi? Or is it option green, Rajnath Singh? So you have to select the correct option and the quick. Amit Shah, Draupadi Murmu, Narendra Modi or Rajnath Singh. So this is a demo quiz. This is a demo question just so that you get a hang of how to play the game. Last second. And the correct answer is Narendra Modi. Okay, moving on to the second demo question. We have which of the following is the national capital of India? Is it red, Mumbai? Is it blue, Kolkata? Is it yellow, New Delhi? Or is it green, Bangalore? So you have to answer the correct answer, capital of India, Mumbai, Kolkata, New Delhi, Bangalore. Last 10 seconds. This is a demo quiz, so don't worry. This is just to understand how to play the game. And the correct answer, as we know, is New Delhi. So we have a scoreboard, but as you know, this doesn't count, and this is just a demo quiz. So let me now try and share the main quiz. Okay, this is now the main quiz for this January session on management of malignant bone tumors. We'll be generating a game pin. So again, the same way, you have to enter it in the app, Kahoot app, or you can also play it online on kahoot.com. And once the game pin is generated, the participants will join. We'll give them a few minutes for them to join. As you said, we are expecting at least 20 to 30 participants in this. So the game pin for the main quiz is 955459. So enter this in the Kahoot app and join the main quiz. We'll give them a few minutes to join. As you know, the trick is to answer correctly and answer quickly. I see quite a few participants joining in. Please make sure your name is, understandable, because we'll be selecting the winners on that. So game pin is 955459. We have around 20 participants. We'll just wait for a few more minutes before starting the game. This quiz will be based on what was taught today and the management of malignant bone tumors. It's a pretty straightforward basic quiz. Okay, so that number is stabilized around 20. So I'll just wait for a minute more before going ahead with the quiz. Game pin is 955459. Okay, Dr. Suman, shall we go ahead?
Yeah, please.
Yes. So we're going to start with the quiz. So the rules are simple: answer quickly, answer correctly. Okay, starting with the first question of this quiz. James Stephen Ewing, who described Ewing's sarcoma, was a red medical oncologist, blue orthopedic surgeon, yellow pathologist, or green radiologist. James Stephen Ewing, the one who has described Ewing's sarcoma, was a medical oncologist, an orthopedic surgeon, a pathologist, or a radiologist. You have last 6 seconds to answer this. Pretty straightforward question. Yes. So the answer is he was a pathologist. So Dr. Suman sir, if you just shed a few lines on that.
It's a quite a easy answer, right? Because it was in, I think, 1800 or something. So that time there was no medical oncologist or radiation oncologist. And we know usually orthopedics are not that smart or into the research to get with this diagnosis. So it was by a pathologist. Yes. And few things about Ewing's is he's from America. And one more important thing I read about him is he's one among 14 who described osteomyelitis. Okay, so he was also part of the team which described osteomyelitis, and he was working at Memorial Sloan Kettering Hospital. So that's about him.
Yeah, thank you for that piece of trivia. So after the first question, we have got Dinesh who's leading. So others have a chance to catch up. Remember, answer quickly, answer correctly. So moving on to the second question of this quiz. Before advent of PET scan, what was the standard staging protocol for Ewing sarcoma? Was it CT thorax only? Was it bone scan only? Was it CT thorax plus bone scan? Was it CT thorax plus bone scan plus bone marrow biopsy? You have red CT thorax, blue bone scan, yellow CT thorax plus bone scan, or green CT thorax, bone scan, and even bone marrow biopsy. Before PET, the staging for Ewing sarcoma. Last 2 seconds to answer that. And the correct answer is CT thorax plus bone scan plus bone marrow biopsy. Quite a few have answered CT thorax plus bone scan only. So if Dr. Suman can just clear that confusion.
Yeah, it shows how many were listening to the talk actually. So yes, we know that Ewing has this characteristic nature of spreading to marrow, having marrow mets and lung mets as well as the bone mets. So it is better to combine with CT thorax, bone scan, and marrow biopsy. So nowadays it has been replaced by PET CT scan because it is non-invasive and the sensitivity specificity is almost same or even more than this procedure. So nowadays we prefer PET CT. If you don't have PET CT, then these three are the options.
Yes, thank you for that. So now we will not see the scoreboard. We'll move on to the third question. Lee-Fraumeni syndrome increases risk of following tumors except red breast cancer, blue chondrosarcoma, yellow leukemias, or green osteosarcoma. Lee-Fraumeni syndrome increases the risk of the following tumors except breast cancer, chondrosarcoma, leukemias, or osteosarcoma? Last 5 seconds to answer that. 3, 2, 1. And there has been a dispersal of the answers. The correct answer is obviously blue chondrosarcoma. Dr. Suman, if you can just clear that.
Yes, so we have read one of the syndromes which are associated with osteos and breast and the leukemias is the Lee-Frommel syndrome, but chondrosarcomas usually the reason is unknown. So we don't know the reason for exactly for the chondrosarcoma. So here the option, the answer is the
Yes, Lee-Frommel can cause a number of cancers, but chondrosarcoma is not a commonly caused one. Okay, moving on to the next question. We have malignant transformation of an osteochondroma is more likely to be a red primary chondrosarcoma, blue secondary chondrosarcoma, yellow osteosarcoma, or green synovial sarcoma. Malignant transformation of an osteochondroma is into a primary chondrosarcoma, a secondary chondrosarcoma, osteosarcoma, or synovial sarcoma. Last 5 seconds to answer that. 3, 2, 1. We have the answer before that. The answer is blue secondary chondrosarcoma. Dr. Suman can just clarify that point.
So the component which goes for malignant transformation in osteochondroma is the cartilaginous part. That's a cartilaginous cap which goes into malignant transformation. So they most likely go into secondary chondrosarcoma than osteo or synovial sarcoma. And primary sarcoma, chondrosarcoma is a de novo sarcoma, so that is ruled out. So any cartilage cap of more than 2 centimeters should raise the suspicion of malignant transformation in an osteochondroma.
Yes. Thank you for that clarification. So there has been a lot of hustle in the table, which we'll see after this question. All are variants of chondrosarcoma except clear cell chondrosarcoma, blue dedifferentiated chondrosarcoma, yellow mesenchymal chondrosarcoma, or green osteogenic chondrosarcoma. The 4 answers, all are variants of chondrosarcoma except clear cell, dedifferentiated, mesenchymal, or osteogenic. So which is not a variant of chondrosarcoma among these 4? 3, 2, 1. And the correct answer is green osteogenic chondrosarcoma. The others are known components. Dr. Suman?
Yes, it's a little tricky question because we know chondroplastic osteosarcoma, but you have put it as a osteogenic chondrosarcoma. So the one thing the postgraduate keep in mind is there are other 3 varieties of chondrosarcomas which are there: clear cell, dedifferentiated, and mesenchymal. And one more point is usually there is no role of chemotherapy in chondrosarcomas, but in dedifferentiated chondrosarcoma and mesenchymal chondrosarcoma, there is a role of chemotherapy.
So that will probably the next level of talks that you will have to take. So moving on to the next question, and before that, the table, there has been quite a few up and downs, and Mr. Shivam is leading now, followed by Vikas and Ebin. Others have a chance to catch up because we are only at the halfway point. So moving on to the 6th question of this quiz. The following variant of osteosarcoma is low grade. Is it chondroblastic OGS? Is it osteoblastic OGS? Is it parosteal OGS? Or is it telangiectatic OGS? Which of the following variant of osteosarcoma is low grade? Chondroblastic, osteoblastic, parosteal, or telangiectatic? We have last 7 seconds to answer that. 3, 2, 1. Bit of a confusion in this question. There are a few who didn't answer, but the majority who answered have got it correct. Parosteal OGS. Dr. Suman, if you can just clear that point.
I'm so happy that most of them got the right answer. So based on the grade, osteosarcomas are classified in 3 types: low, intermediate, and high grade. So in the low grade, which comes is the parosteal osteosarcoma, and another variety is the low-grade osteosarcoma, surface osteosarcoma. And the intermediate is the periosteal osteosarcoma, and all other varieties comes into high grade. So one thing you need to remember is, in osteosarcoma, what we discussed is usually we give chemotherapy, then do the surgery, and then add chemotherapy. In low grade, that is in the parosteal, usually we do surgery upfront and we don't give chemotherapy before the surgery.
Yes, yes. Thank you for that. And now moving on to the next question, which is again on osteosarcoma. 20-year-old male presented with the following MRI. It is likely to be the following variant of osteosarcoma: red chondroblastic OGS, blue osteoblastic OGS, yellow parosteal OGS, or green telangiectatic OGS. The MRI that is shown is more typical of which of the following variants of osteosarcoma: chondroblastic, osteoblastic, parosteal, or telangiectatic? You have last 5 seconds to answer that. 3, 2, 1. And the correct answer, as we know, is telangiectatic. I'll just show the MRI again, and Dr. Suman can describe as to why is that.
So it's very important because this is the differential diagnosis in most of the cases, and always people confuse it to be a primary ABC and try to operate, and it turns out to be telangiectatic osteosarcoma. So the most important thing what we need to see is, or the confusing thing is, the fluid level, which can be seen in aneurysmal bone cyst. Okay, so any case where there is a fluid level with associated solid component, we should always suspect something else with aneurysmal bone cyst, and we have to be very careful, do the biopsy and treat it accordingly.
Yes, yes. Thank you for that point. So at the end of 7 questions, again there is a change, and Vikas is now leading the table. Shivam, Ebin, Dinesh, and Mr. C have a chance to catch up in the subsequent questions. Let's go ahead and let's see the 8th question. What is the usual protocol in treatment of osteosarcoma? Is it red, surgery? Is it blue, surgery plus adjuvant radiotherapy? Is it neoadjuvant chemotherapy plus surgery plus adjuvant chemotherapy? Or is it green, neoadjuvant radiotherapy followed by surgery? Which of the following is the usual protocol in treatment of osteosarcoma? Surgery, surgery plus adjuvant radio, neoadjuvant chemo followed by surgery followed by adjuvant chemo, or is it green, neoadjuvant radio followed by surgery?
Everyone should get it.
Almost everyone did get it right. Neoadjuvant chemotherapy
Yes.
plus surgery plus adjuvant chemotherapy.
So that's fantastic. So we all discussed. So the role of chemotherapy in osteosarcomas: one, they shrinks the tumor, make it less vascular, gives a better margin, and also gives the necrosis, which helps to know the prognosis of the patient. So chemotherapy is a very integral part in osteosarcoma. We always start with chemotherapy, which usually goes for 3 months, followed by surgery and again chemo.
Yes, yes. Thank you for that. Moving on to the 9th question, and we'll have a look at this table after the end of 10 questions. Which of the following tumors is radiosensitive? Is it red, osteosarcoma? Is it blue, Ewing sarcoma? Is it yellow, chondrosarcoma? Or green, all of the above? This was discussed in Dr. Nehal's talk. Which of the following tumors is radiosensitive? Osteo, Ewing, chondro, or all are radiosensitive? Last 5 seconds to answer that. 3, 2, 1. And almost everyone did get it right. Ewing sarcoma is the tumor, radiosensitive tumor here. So, any line that you would like to add, Dr. Suman?
No, I am so happy. So many, at least they listen to the talk, and they at least it's there in mind that the radiotherapy works in Ewing's. So the role of radiotherapy in Ewing's comes in 2 ways. One, you do the surgery and give radiation after the surgery in few indications like what Dr. Vishnu mentioned, where the margin is close or microscopic positive margin, or there is a pathological fracture initially which was there, or if there is a improper open hidden biopsy when you are expecting the contamination, you add post-operative therapy. The second indication is when we just treat with radiotherapy without surgery, in cases where the surgery is very morbid. So that time we can treat it even with only radiotherapy. So that works only with EVISAP.
Yes. So moving on, and we'll now jump to the last question. The final question of this quiz. The following drug is not used in osteosarcoma. Is it low dose methotrexate, high dose methotrexate, doxorubicin, or ifosfamide? Discussed by Dr. Badira. Which of the following drug is not used in osteosarcoma? Low dose methotrexate, high dose methotrexate, doxorubicin, also known as atreomycin, or green ifosfamide. Last 3 seconds, 2, 1, and that's the end. And low dose methotrexate is the correct answer here.
Yes. So the low dose methotrexate does not work in osteosarcoma. So the word is very specific because only high dose works with osteosarcoma cells. So that is more than 12 milligrams. So that is what we call it as high dose methotrexate. And as Dr. Badira mentioned, so there are two chemo regimens which we practice in osteosarcoma. One is methotrexate based, another one is without methotrexate, that is IAP based, Adria, IFAS, and cisplatin. So overall, head-to-head studies, they're showing similar result with these two. So that's about chemotherapy in osteosarcoma. But yes, in this, the high dose methotrexate is the one which we recommend in osteosarcoma.
Yes. So now that concludes the quiz, and now we will see who is on the podium. So on third position, we have got Shivam M. And in second, we have Dinesh R. And in first position, we have Dr. Ebin. That is fantastic. If Dr. Ebin is present, we can have him share his video and give a few thoughts about the session. Congratulations to all the podium winners.
Congratulations to everyone who participated. That's most important.
Yes. So, Dr. Ebin, if you can just share a few words about your experience in playing the quiz and more importantly on the session.
It was a beautiful session, very informative. Lots of concepts have been discussed with eminent faculties. And also the quiz was very competitive, very good curated questions.
Thank you for that. So I think that concludes our session for today with Dr. Suman.
Yeah, so thank you so much, Pratik, because the main person behind all this is Mr. Pratik. He has done a fantastic job coordinating with me, with the other faculties, and organizing such a fantastic session. And last but not the least, Dr. Ashish Gulia for creating this fantastic program, which is helping PGs. And each session, we are having more PGs registering and getting information out of it. So thank you so much. Have a great weekend, everyone. Thank you.
Yes, thank you all for participating, and do join us for next month, where we will have a session on management of soft tissue sarcomas. That will be Dr. Anand Raja, and we'll also have a good panelists again for that. Thank you all.